Next witness is Bill Hammond.
Good morning.
If you'll identify yourself for the record, and then I'll swear you in.
Bill Hammond from the Empire Center.
And do you swear or affirm that the testimony you're about to give is true?
I do.
Okay. Welcome.
So, I've heard a lot of discussion today already about the global cap as one of the topics of the hearing. And I think I want to do a little reality check on that.
Do you speak a little closer into the mic?
I want to do a little reality check on how the global cap works. It's based on the rolling average of the medical inflation rate. From the beginning, it only applied to the state share of Medicaid. And so when federal aid increased more than the medical inflation rate, that did not affect the global cap. Over time, more things were exempted from the global cap, probably most significantly a lot of extra funding related to the minimum wage increase. The net effect is that although the global cap nominally kept state spending to a little over 3%, during the period, I picked a 3-year period, 2017 to 2020. The nominal global cap was 3.2%. State spending actually went up 4.6%, and total Medicaid spending went up 5%. So the global cap was not as strict as it would appear to be at first glance. I would also say that it was never enforced the way it was meant to be enforced. The authority of the health commissioner to unilaterally cut programs or spending has never been invoked. There was a moment when it probably should have been invoked during the 2019 fiscal year when Medicaid spending went significantly over budget. And instead of using that authority to contain things and to keep things on budget, they delayed a set of payments from one fiscal year to the next, excuse me, which created a deficit which led to the much bemoaned MRT2 and the need to do cost cutting in the middle of a pandemic. So had the global cap been better enforced, better respected, you might have avoided that scenario. I heard today from the earlier testimony stories about people not getting their needs met, acute, very needy people not getting the services that they need. At the same time, we have seen the number of people in this program really mushroom. When this century began, we were at, it was like 15% of the population was on Medicaid. In 2010, it was up to 24%, and now it's over 33%. So you have a program that's not adequately meeting the needs of the most vulnerable people, and it's adding millions and millions of more citizens to the program with no end in sight. It's like I say, it's doubled in size since the beginning of the century. And the question is, I would say it looks like we're prioritizing quantity of coverage over quality of coverage. And I would argue that if you got a handle on the quantity of coverage, if you focused on the really needy people, the people with who are seriously disabled and indigent, and you gave them better coverage, in other words, you compensated the providers better, you would serve them well, and then try to create a commercial insurance system that serves as many as possible of everyone else. Try to get that Medicaid enrollment number down lower than 33%, and then reinvest the savings, at least some of those savings, in improving the quality of care for the neediest group. You often hear including today, you hear providers come and talk about all the different things that have been cut from their rates. The overall picture of Medicaid has not been one of cuts. During the 10 years that Governor Cuomo was in office, Medicaid enrollment went up. I have it here somewhere. Medicaid enrollment went up 1.3 million, or 29%, and spending went up 22 billion, or 41%. Per recipient spending, every measure of our Medicaid program is that it's big, it's generous, and it's expensive compared to other states. And yet, we do hear from providers that they're not getting paid adequately, and frankly, I don't think there's any argument about that. The Medicaid program pays the lowest of any major payer. It pays 5%, roughly 5% less than Medicare, and 43% less than commercial insurance. If you want a better healthcare system, it seems to me you want to move more people into that commercial insurance system where there's more money on the table to pay the providers, and you could, if you had a smaller Medicaid system, you could invest more in each of the recipients instead of the way we do it now. I haven't used my time, but that's what I wanted to say.
Well, thank you. If we move more Medicaid enrollees into the private system, the funding for that would have to come from somewhere. And the reason people are in Medicaid is because they don't carry funding with them.
One demographic point I could make about what's been going on, during the past decade, most of the past decade, the state's poverty rate was coming down, which is a good thing. The number of people in the income category that Medicaid theoretically focuses on, below 138% of poverty, that group got smaller. The number of insured people in that group got smaller while Medicaid was growing. As of 2019, if you look at census data, and I'm not going to say that these census data are absolutely precise, but they indicate that a majority of Medicaid enrollees were above 138% of poverty. That's where the growth has been. Now, I'm not going to say those people are rich. It's not going to be easy for them to buy health insurance. But if their employer offered health insurance, they could probably afford that. And if the state supported employers in providing insurance, and if it maybe enhanced some of the incentives and the tax credits in the Obamacare exchanges, and if you combine that with a new approach to regulating health insurance that actually lowered the cost and brought it closer to being affordable, you could gradually move people away from the public assistance system and into the self-support system, with a huge benefit to the healthcare system because the commercial system pays better, savings for the state. The costs to the state are not just in terms of the dollars spent on Medicaid. It's the fact that they're crowding out spending on other priorities. And a pretty glaring example that came to light in the last 2 years is that within the health department, the department that runs Medicaid, it has other things it does, what are sometimes called public health. It runs the Wadsworth Center that did all that testing during the pandemic. It inspects nursing homes. It has a laundry list of things it's supposed to do other than Medicaid. Those programs collectively have seen their funding flat or declining. Wadsworth Labs, it has half the budget it had when Governor Cuomo took over, and about a third of the staff, at least in terms of what we can see publicly. That is a byproduct of a choice that the state has made to put all of its chips on Medicaid and school aid as well, and then not to disinvest in other areas of the state budget.
Well, not for today's topic, but I could mention that the other obvious solution to the problem of Medicaid is the New York Health Act, but that's for another day's hearing.
May I address that?
Sure.
I mean, a lot of what would happen with the New York Health Act would depend on how well it compensates people. Right now we have two examples of a government-run healthcare system. One is Medicare and one is Medicaid. Medicaid is run by the state, the same entity that would run the New York Health Act, and it's paying the lowest of all the health plans. It's lower than Medicare, and it's dramatically lower than commercial insurance. So the question is, it's hard to know, based on the legislation itself, how well this system would pay. It would be sort of taking the issue that I've laid out, it would be taking it to the ultimate extreme, where I said we were prioritizing quantity over quality. You'd be going all the way to 100% of the state would be enrolled in something like Medicaid. And what reason do we have to expect that it would function better for needy people than the current system does?
Yeah. Well, the quick answer to that is that if the governor and me and my family and all my friends are in the plan, we have a very real stake in making sure that it is not run the way Medicaid is run today. But we're getting off on an important tangent, but a tangent. Would it make sense, getting back to the question of the Medicaid cap, would it make sense for that cap to be adjusted to accommodate things like increased enrollment, particularly an increase in the proportion of the enrollment that is attributable to older adults who have much higher, particularly long-term care needs? Would it make sense to add that as a factor?
I have to say, I think parts of the cap are useful, especially the monthly reporting, which doesn't get done, and the option that the management team of the state, which is the health department, the executive branch, should have the ability to manage the spending on one of the largest programs that the state has. It's tricky to manage because parts of it are entitlements, and so how much you spend depends on how many people walk in the door and apply and what benefits they need. It's hard to manage. I think the state needs to have some tools in the course of a fiscal year without going back to the legislature. If something starts to spiral, they should have the ability to do that. It would, like I say, it would help avoid situations like what we saw in the spring of 2020, where we had a crisis, we had a deficit, and we had to take, actions that people didn't want to take at that particular moment. So the thing is, those are the parts of the cap that I think remain relevant, and yet they've never been invoked. They've been widely disregarded, and I'm not sure how you make them stick. If the executive branch doesn't want to use them, it's hard to force the executive branch to use them. In terms of where you set the percentage, I mean, I'm of the opinion that we have too many people in the program. And so if you adjust the cap to reflect higher enrollment, you're going to defeat my purpose anyway. I'm not sure how to set some kind of arbitrary percentage that's going to be appropriate. I just don't think it's right now. I think it's almost more of a license to spend than a restraint, and I'll explain what I mean by that. The overall budget has been held at 2%. The nominal amount of the global cap is 3%. The actual growth of Medicaid is 5%. If you are in the state budget and you're a program, you want to be part of Medicaid because that's going to be allowed to grow faster than the rest of the budget. If a program can be sentient and have desires, that's what they would want.
So, some would argue that a lot of the discussion about social determinants of health is an effort to, in some ways, almost do exactly that. Have the health budget take over responsibility for helping people get housing and any number of other things.
Again, I think that is absolutely appropriate in the cases of very needy people who aren't able to take care of their own, aren't able to support themselves. That's not what Medicaid is right now. Medicaid is a third of the state. I don't think the descriptor that I just used, very needy people who can't take care of themselves, applies to a third of the whole state. Mm-hmm. I don't know what the exact percentage is. I don't know what the cutoff would be, but I think a third is more like it's now really two programs. It's a program for people who are physically disabled, developmentally disabled, mentally disabled, people who really do have a tough time supporting themselves and have really expensive health care needs. And then there's a broader group who are people who just didn't have health insurance. They might even have a job. They might be young and healthy. And Medicaid is now available to them, and it has no premiums and no copays, and so it's attractive in that way. There's two different programs, and one is competing with the other for resources, and I think that ends up every year we have representatives of groups that serve the seriously disabled, people who run group homes and nursing homes and things like that. They come to the legislature and they say, we don't have enough money to provide the right kind of care. We can't hire people. And sometimes they get their needs get addressed, but they get addressed as like a percentage of the whole program, which is also addressing the needs of the people who are in that 33%. It's a question of priorities.
Other questions? Yeah.
I have a question, and thank you for coming today. You referenced how New York spends more on Medicaid compared to other states. Is there something that other states are doing that we could learn from that would help us contain costs?
I mean, it's a good thought. It's hard to attribute it to one factor. We have, high enrollment, as I've mentioned. We have if there's an optional benefit available in Medicaid, New York tends to offer it. We also have high per recipient costs, probably because we're an expensive state, and a lot of Medicaid is concentrated in the New York City area where things are generally expensive. But I'll give you an example of something that's been getting really expensive lately and where we are just an absolute outlier, and that's home care, the whole category of sending caregivers into the home of somebody who's disabled and needs help. When Governor Cuomo took over as governor, he became governor, New York accounted for 40% of home care by Medicaid in the country. One state was 40%. Since that time, I said it was 40% in 2016. Since 2016, our spending in that area has doubled. We had just a massive influx of enrollment of people who were then deemed to be eligible for home care. No other state comes close to us in terms of the number of people we provide home care to. And I think one reason is that New York has decided to treat it as an entitlement. If you meet the basic requirements in terms of income and the disability screening, you're signed up for it. You may have trouble getting it for reasons, as we've heard today. Either a plan is limiting your service or you can't find somebody to hire. Other states have treated it as like you have to apply, and they have a limited set of slots which they allocate to people that they identify as being the most appropriate for this type of care. I mean, I think that bears further investigation, and looking at what other states do would be a really good approach.
Thank you.
A question, since you're from the Empire State of Policy, right? I have a question. Have the organization ever looked at how much does New Yorkers spend exactly on health care? Like the average New Yorker who's not needy, as you said.
It's somewhere in the neighborhood of, if you have employer-sponsored insurance, it's somewhere in the neighborhood of $78,000 a year.
$70,000 a year.
That's high. New York has high premiums, in part because of policies that are determined in the legislature.
Right.
We have taxes on health insurance that finance Medicaid. We have a laundry list of things that insurance needs to cover. One thing I would advocate is that the state should kind of back off from some of that and help insurance become less expensive.
Okay. You had talked about some of the reasons why enrollment has gone, like you talked about enrollment a lot. Can you give a little bit more, what happened between 2016, 2020, where you saw that enrollment? I saw that you talked about some of the people who were enrolled over 130%, 38%, right? But I wanted to can you give me a little bit more about what is happening? Why are people enrolling more into Medicaid?
I was talking about two different things. One was overall enrollment went up. It's now it's somewhere over 33%. And when Governor Cuomo took over, it was about a quarter of the state. So that's the increase in total enrollment. And I was trying to point out that increase in total enrollment was almost entirely people who are technically above the poverty level. It's not to say they aren't low income, but they're not below the federal definition of poverty, because the number of people below the federal definition of poverty in New York, thankfully, has been getting smaller because of economic forces. So when Medicaid grew, it wasn't because our population got poorer, it was because our Medicaid program was expanding into a larger group of people. With respect to the home care is actually pretty small group of people. It's in the tens of thousands, maybe in the low hundreds of thousands. But each person in that category tends to be really expensive. And so, like I say, we offer that benefit to a much larger share of our population than any other state. And that grew rapidly in the last decade.
You had recommended that we limit some of that enrollment, but then with $70,000 cost of health care alone.
7 or 8,000.
Oh, 7 or 8,000.
And then often, if you get your insurance through your employer, you don't pay that out of pocket. Like, you and your employer split it. That's typically what happens. A lot of us who have insurance through our employers are, we don't think of it as part of our salary. It really is part of our salary. It's part of our compensation, if you will. It's more expensive than I think most of us realize. Family coverage can be $20,000. I think we should work on lowering that cost. We certainly shouldn't be aggravating the situation with taxes and regulations that drive up that cost. But there is an opportunity to get more people into that system without, driving them into abject poverty. It would require some contribution from them. I contribute. I think most of the people in this room contribute to their own health insurance. I think that's an appropriate way to deal with the vast majority of people in the state of New York.
Thank you.
Okay. Thank you very much.
Thank you.
Okay, our next witness is Helen Schaub.